Welcome again, very warmly. My name is Dominika Sikora and I am Deputy Editor-in-Chief in Dziennik Gazeta Prawna. I will have the pleasure to moderate the first part of today's meeting, today's event, a debate towards improving cardiovascular health in Poland, conclusions and recommendations from PwC report. But before we start presenting the results of the report and the panel, we have some changes. Hopefully, we are already hearing Adam Jarubas, MEP and Chairman of the Health Committee. Sant, can you hear us? Yes, yes, I can hear you. So, without further ado, since we know that you are very much involved in the new assembly of the European Parliament, my first question would be, what would you expect during the Polish presidency of the Council of the EU when it comes to cardiovascular health, and what about the European level? Can it help in this respect? Good morning, ladies and gentlemen. Greetings. I apologize for this forceful taking the first turn before other representatives of multiple communities operating for the benefit of the patients. The thing is that in 30 minutes we have a coordination meeting, a preparatory meeting of the new Health Commission that I am a chairman of. So tomorrow there's going to be its first formal meeting after creating this format of a full legislative health care commission. So thank you for having me in this meeting. There is indeed certain awareness, not only in Poland but in other member states in the EU in general, when it comes to the healthcare union. We do realize that we have to focus on the European level as well on the biggest killer, the major killer of today, namely cardiovascular diseases. They are responsible for 36% of deaths in Poland. 175,000 people die because of cardiovascular diseases in Poland every year. It is estimated that annual cost of treating them in the EU exceeds 200 billion euro. And other than that, there are economic outcomes as well. The outcomes that are associated with loss of productivity and workplace absence. In the previous term of the European Parliament, we witnessed the birth of the European healthcare policy. A strong impulse to that was the pandemic of COVID-19, which made us realize that we can be more effective when operating together. But even before then, by the Polish initiative, which is important to emphasize, there was a European program to combat cancer established on the European level as well, and that program is going to be reviewed very soon these days. Also, on the basis of implementing this program of combating cancer, here at the Commission and the Permanent Subcommission for Health in the Parliament, we realized that basing on this foundation of oncology, it would be good to build other coordinated European programs referring to other important disease entities and therapeutic areas. And here, what happens in the foreground is the cardiovascular program, also neurodegenerative disorders and mental health in general. so various brain related disorders as well. So today there is an expectation, a very shared and common expectations that the newly appointed healthcare commission together with the European Commission are going to work hand in hand to create a European program focusing on cardiovascular diseases so that these efforts are fully coordinated on a European level, the efforts of member states, so that we have certain standards when it comes to efficacy of treatment, but also prevention, screening programs, and so on. We do notice a significant deficit in this respect. In the broad sense of health, much is happening these days. Let me mention the European healthcare data space, which is also a chance for a more effective research and accessing a broader pool of healthcare data. Telemedicine, in the case of cardiovascular diseases, is also an area that could be, or well, it could definitely be more utilized. What we have already successfully done, what we have confirmed on the European level is something that was visible in Ursula von der Leyen statement, as well as Oliver Varhelye, the new Commissioner for Health. We do hear that the European Commission is going to indeed prepare a program like that, and in just a moment we will learn about the main assumptions of that program. Somewhere in the background, there is a debate happening on the pharmaceutical package and a legal act on critical medication. A tremendous challenge that is being pointed out by MEPs are the differences in access to healthcare benefits, differences between member states, but also various areas within the member states. As Professor Maciejczuk said, health may depend on your DNA code, but it shouldn't depend on your zip code. So I think from the perspective of countries like Poland, it is a chance, it is an opportunity to reduce the distance to healthcare, access to healthcare. It's also a good opportunity to show what sort of innovations are developing in our country, what innovations are available in our country, like vaccinations that are used in the therapy of atherosclerosis. This could be an example. Of course, the most important thing that we can do for our health needs to be done locally. So in Poland, we have to remember that health remains the unique competence of the member state. However, there is a conviction that it would be good to also spread some European initiatives in this respect in order to develop shared standards and coordinate work of researchers looking for novel therapies. So thank you again for having me. I'm keeping my fingers crossed for the fruit of this meeting, this conference, and I encourage you to work together. Thank you very much for being with us. And now over to the next stage of our event today, and I would like to invite Mariusz Ignatowicz from PwC, who's going to present the report specially developed for this occasion. Yes, thank you very much. Welcome. My name is Mariusz Ignatowicz. I'm the advisor of the board of PwC for healthcare, and it is an honor for me to present this report for you today and communicate our main conclusions of the report prepared by Infarma and FPA, focusing on one of the biggest challenges, healthcare challenges in our country. Like the MEP said a moment ago, every year, cardiovascular diseases kill over 160 people in Poland, meaning 1/3 people dying in Poland die of cardiovascular diseases, which is why what's necessary is to keep talking about what else can be done, because despite we have many initiatives, still things need to change. So the report I will present to you was created by the initiative of the European Federation of Pharmaceutical Industry in collaboration with the Polish Association of the Employers of Innovative Pharmaceutical Companies, so Inpharma and PwC. It was developed as a part of a bigger whole, a program that was initiated in 2022. It was a shared report by PwC and APPIA, focusing on the cardiovascular diseases in the pan-European dimension. Then the report was drafted focusing on Spain, and this year we have a chance to discuss conclusions regarding the situation specifically in Poland. The ambition behind this report was to analyze the situation within the market, the initiatives, the activities that are being taken already, but not only that, also to propose very specific implementable solutions that could potentially change the situation, improve it, taking into account best knowledge and best intentions of all the stakeholders holders functioning within the market. The development of this report would not have been possible without the involvement, passion, and participation of all those who co-authored this report, in particular our panelists, who took part in our round table. Some of them you can see right here. So some of them are present with us here today, and they will be part of our panel discussion. So once again, I would like to thank them for their contribution. And the fact that we had a diversity among our members, because we had specialists representing cardiology, diabetology, nephrology, but also specialists of other medical disciplines. And as a result, our conclusions are very comprehensive, but they are also implementable. They are practical. And they are very specific and possible to become operational. But we also need to remember that despite many changes, despite rising awareness when it comes to cardiovascular diseases, all the activities that have been taken so far, even though they are taking us in the right direction, they are not enough. They are not sufficient considering the needs that are out there. During our discussion, sometimes this discussion was very stormy. Sometimes it was an argument. Sometimes we were exchanging opinions and experiences. We were proposing various solutions. But as a result, together, we reached a consensus regarding two main priorities. According to our panel of experts, these are the pillars that we should focus on in the nearest future. The first point to focus on is or regards an effective system of conducting screening. A system that would ensure effective and quick detection of risk factors in the potentially broadest groups of the population, so that implementation of prevention and further on diagnosis and treatment could happen as early as possible and could lead to optimum therapeutic outcomes. What is also necessary is coordination of activities surrounding screening, because as the results of our analyses indicate, the willingness to participate by the patients in preventive programs is not perfect. A good example to illustrate that would be a preventive program for 40+ individuals. It's a common program accessible to everyone over the age of 40 who can take part in it, but less than 20% of those entitled decided to take part in it. Those programs do make sense. Another program called Lipidogram revealed that in 80% of patients included in this program, some lipid abnormalities were detected, and those patients were not aware of any such problems. And so it is worthy to take part in these programs. It is worthy to organize them. However, what we have to do is raise public awareness and increase the willingness of our patients to take part in those programs, but also coordination is necessary when it comes to the results that are obtained in the program. So processing data and managing patients' journey after potentially early diagnosis. Another main pillar that was a focus of our discussion, that was identified as one of the key factors here, was the area regarding equality of access. And that is something that was mentioned by our MEP. The thing is that these days, to many people, access to healthcare is limited, whether because of geographic factors, especially when we are talking about Eastern Poland, because of existing infrastructure, the cost of accessing a specialist, that access is limited. On the other hand, we are also dealing with certain economic limitations. From the studies conducted by PTK, we see that 2/3 of patients on various cardiac medications, they take at least two agents that are fully paid out of pocket, which is a barrier for many people when it comes to accessing optimal treatment. Having identified those two key areas, our discussion revolved around the challenges that are out there within those two focus areas. We talked about what could potentially be changed. So the first challenge is going to be creating a comprehensive model for conducting screening, because the current existing system tends to be very fragmented. It is not coordinated in its nature. Very often, certain testing or tests are being interrupted, repeated, and that impairs comparability of data, which in turn limits the usability of that data at a later stage. For instance, to plan or to shape our drug policies or healthcare policies in a broad sense. Another stage is, well, even if we do collect data in a program, we don't have a single data center that would be able to process it effectively and then use that to shape healthcare policy. And last but not least, the patient. Even if the patient is screened, and in the course of this screening, the patient is diagnosed with the problem, there is no simple, straightforward patient journey. So the patient gets a diagnosis, but many a time it happens that a patient is left alone to look for help, sometimes in a randomly chosen center. Then the other pillar, the second pillar, accessibility and equality of access. Like I said before, there are limitations to it, and the challenge is both ensuring geographic equality or demographic equality, as well as economic equality, but also equality to access when we compare Poland against other member states of the EU. And here, this postulate focuses mostly on a more rapid and easier evaluation and allowing new medical technologies, also reimbursing them and covering new medications with a reimbursement option. So to summarize, we have identified 4 key guidelines developed by our panel of experts, the guidelines that we would like to leave with you as a food for thought, and I'm sure that's going to be a topic for further analysis and discussion by our experts here on this stage. So first of all, introducing a comprehensive approach to screening programs, so that those programs are able to diagnose risk factors early on, monitor them, follow them up, and then limit the risk of more acute conditions, hospitalizations, and thus limiting cost. The second element would be having a situation when we are able to use a pilot project and shape the future of national cardiology networks. They could be a skeleton around which the patient would go. So the patient would know where to go, where they would be provided with comprehensive care, and they would not be left to their own devices. Then another element is evidence-based medicine, really, because I'm talking about the use of all the data that we can compile during those coordinated, comprehensive screening programs, but using them in such a way that on this foundation we could create postulates based on data, based on the numbers, and thus better shaping healthcare policy. And the final thing is adapting financing to current trends, medical trends, and medical knowledge. So more frequent and more rapid review of new medical procedures, faster approval and registration of new therapies, and facilitating access to patients to these new therapies. So this was a very brief presentation of something that took us months to develop. So many different recommendations, but I want to thank you for those minutes that you devoted to me. Now it's time to give the floor to our moderator and to our panelists, to our panel. So I hope you have a very fruitful discussion. Right, thank you. And now over to, please, of course, stay with us, but we are slightly delayed. So let me just very quickly present our panelists, Professor Robert Gil, head of the Polish Cardiac Society, Professor Maciej Banach from the Polish Lipid Association, Professor Krzysztof Chlebus from the Gdańsk Medical University, Professor Krystian Wita from the Silesian Medical University, Konrad Korbiński, head of the Department of Coordinated Care at the Ministry of Health, Agnieszka Wołczenko from the National Association of Patients with Cardiovascular Diseases, ECO Serce, and Michał Byliniak from Infarma. We also have Senator Agnieszka Gorgoń-Komor, who's Deputy Chairwoman of the Senate Healthcare Commission. Yes, welcome, ladies and gentlemen. Welcome, Madam Senator. I'm hoping that Professor Agnieszka Pawlak is going to also join us. She's representing the Polish Cardiac Society. So, ladies and gentlemen, not to prolong, I hope that during this debate we will be able to say what to do in order to improve the diagnosis and treatment of cardiovascular diseases in Poland, what to do to make Polish people more appreciative of the prevention. So that's what we will talk about. But I want to start with a question to Professor Gil. Professor Gil wrote a preface to the report. So my question is, how do we build a system to make it efficient, effective from the point of view of the payer, the patient, the treatment, because there are various points of view here that are going to impact the system. So how do we make it both effective and efficient? Well, thank you for having me. Well, ladies and gentlemen, there is no easy answer to this question because there is no single perfect system. It's not, something that we see far ahead beyond the glass and we just need to reach for it. No, I think we have to strive to create a system where the stakeholders, the healthcare professionals see the logic in it. The payer is convinced that they can afford the tasks put in front of them, and as a result, the patient is going to say, yes, this is effective, I accept it, even though it is not offering everything I want. At least I know that that could get better in the years to come. So I think we should have a very reasonable, sensible approach to it. So let's not promise God knows what. Let's not believe that it's an easy feat. We basically have to build something on the foundation that we already have. Today, I know there are among us here representatives of the opinion that everything needs to be brought down and then we should start from scratch. There are others who say that evolution is better. So I'm saying that we need a middle ground. We need to use what's best in the existing system, making it better with some new elements, the elements also found in this report. But other than that, we need harmony, we need coordination. We are not entirely using the potential of the existing system that we already have. So I think what I've been trying to emphasize in my preface to the report, what really strikes me is that, unfortunately, the three elements of healthcare in Poland, so primary healthcare, specialized outpatient and hospital care, they do not work together. Hospital treatment is overloaded. Primary care is lost somewhere in the mist. There are now certain positive changes because coordination is going to the foreground, and I think that's the direction to go. But we are not really using outpatient specialized care. And it's an intermediary between the primary care and hospital care. So if fitted out with certain diagnostic options, if they could focus on new patients and establishing their patient journeys, that would make it easier for primary care to work, and also it would lower the burden on hospital care. So these are the only rational directions that could really change our reality. And we do see that work is happening. We do see that effort is being done. We see that in the National Cardiology Network, we've got certain elements that are associated with reference levels, and that means that, well, not everyone should do everything. That's my point. If the most severe cases, these are the patients for those who have the most experience and access to the best equipment, because they will be most effective. Which is why reference levels, it could be painful for some centers, I know, but that is a very significant thing, especially that in the next 3 years it could be improved. It doesn't mean that one center thrown into a certain category can never change its reference level. No, so some improvement in the system, improvement in the expertise level, that is something that is also playing a key role. On the other hand, we do see a reversed pyramid. There is work by some specialists working together with the ministry, where we do see we are preparing for that situation, where outpatient specialized care is going to play its proper role. It's going to relieve hospital care a little bit. So let me put it this way. There is many evidence showing that we are going in the right direction. Perhaps we could accelerate, but, you know, we are facing some habits and routines of the old system, so it's not easy to change quickly. I am convinced that if the National Cardiology Network, as planned, starts existing even more than it does already in the second half of this year. If in the second half of the year we do see the reversed pyramid in outpatient specialized care, and coordinated care in primary care is going to develop as it is, because cardiology is already developing in primary care. In December, I actually heard that over 50% of primary care units has already joined the program, and that means that this program is growing and it's going to become more significant to the patient. I always tell my patients who get in touch with me, I tell them, look for the primary care centers that are members of this network for cardiology, because they have more options, they are more ambitious, they work harder, and they will help you better. And I think many new things are already happening. We do not see everything already, but it doesn't mean that we have given up, that we are not fighting. It seems that both the representatives of the Ministry of Health as well as the representatives of the National Health Fund do understand this collaboration is happening. There are meetings every single week. Right, thank you. You said a very interesting thing. What I focused on most was that the system is there. It's not that we have to start from scratch, there is nothing, and we have to build from there. But the challenges are still multiple, especially when it comes to what the ministry is preparing. So the legislative aspect is important here, because without that, you cannot really build the system.
We can also talk about the reverse pyramid of benefits we are also talking about, and there is also financial issue, which is money and the possibility of money absorption from the European funds, in particular from the European Recovery Plan. And one more thing. One thing is missing for me in this report, because when we are looking for vulnerabilities and when we are proposing the improvement, we are not securing the finance. You know, every domain changes. Cardiology is not a discipline which will never develop anymore. New diagnostic techniques, new drugs, new procedures that require more advanced equipment. This is a progress. This is something that is taking place, and this is what I can see there is missing in conclusions. It is like the constant support. Cardiology is encountering the following issue. You have everything. You're one of the best in Europe. What are you missing? Well, it's, for example, diagnostics, like genetic diagnostics in cardiology. We don't have anything to offer here to our patients, and we have to catch up with the rest of the world, because in a moment it will slow down our diagnostics and will actually influence our outcomes. And there is one more thing. I did not talk about the National Recovery Plan, because this is something which is supposed to come, but we do not see this. It is not tangible. But I would like to draw your attention to the European presidency. Everyone believes that this presidency is going to change our reality, but it is not really the case. However, let us use this presidency by promoting the needs as well as working on changing the reality, so that we could continue that 6 months down the road and not rest on doors and say we have achieved everything and we can't do anything more. Thank you very much. My second question of Professor Chlebus, and I would like to refer to what Professor Gill said. The question is whether, in the context of Poland, we can talk about the, the comprehensive plan or counter fighting the cardiovascular diseases, because there are quite many different things. But are they comprehensive? Are they somehow connected with each other? Are they acceptable for patients to navigate around them? Well, we have a problem with that. And there is something which we could call a system. But some dysfunctions of the system or disadvantages of the system were named in the report, as well as in the previous statement of Professor Gill. Let me say that, well, actually, we think we should stress very much the fact that, except for very good trends, epidemiological trends which we have been observing for the last 20 or 30 years, there is some, regression for the last 10, 15 years in terms of the reduction of incidence with cardiovascular diseases. We had beautiful graphs showing the tendencies in the reduction of cardiovascular issues, and, well, it is true, something happened 10 years ago. And I think that this report fits in this huge need that we have to redefine what has happened in the system. And to answer your question directly, I believe that it is time today to stress very emphatically what we already tried to do in the past, but we have to talk about this in public, which is identifying a new role for preventive. Because reparative medicine in cardiology, since Paul Card has been recovering, and we have really impressive achievements, but all the things that are connected with prevention, they should be treated in a very comprehensive way. It is not only about teaching, although it is important and controversial, as it has recently turned out. It is also the controversial teaching and education at the level of public schools. But it is a much broader subject. What Professor Gill is talking about, that is the scope of financing. Let me remind you that as far as cancer is concerned, about over 10 years ago, we had a national program fighting cancer. And it was the first time ever where we had dedicated, allocated funds that were allocated to screen for cancer and prevent cancer development. And I think that if we are not going to fight for that solution in cardiology, I think that we will encounter the problem that the prevention will be actually pushed on the sidelines and it will give way to reparative medicine. But prevention is incredibly important. We have to remember that we are a society of very high cardiovascular risk, which means that today, instead of focusing on treating the consequences, we have to think whether we are able to slow down the dramatic process we've been observing every day. And this is also about such things, well, I'm talking here about the primary and secondary prevention, even something which apparently seems to be very distant. You may think that it is reparative medicine, but it's access to state-of-the-art therapies that would allow us to control lipids, for example, the BO1 program, and this is something about lowering the threshold. So we are talking about this on an everyday basis, but there is also a question whether these drugs can be available as reimbursement for non-oncological drugs. And I think that this is something that we should consider. To conclude, let me say the following. We have some solutions which are ready-made. We have great models that were developed by us for at least 10 years. I have been emphasizing very strongly the fact of the existence of a group of centers in our system that are involved in treating familial hypercholesterolemia. Whenever we are talking about different actions dedicated to that group of high-risk patients, we have to remember that in that huge population of patients that suffer from cardiovascular problems or are going to suffer from them soon, we have a very special group, which is patients that have a genetic defect. And it also is part of what we have already talked about. It is about diagnostics. So if we imagine that we have almost 200,000 people who before 50 years of age will suffer from a stroke or MI, and we know that, and we have tools to prevent that, but we do not diagnose these people effectively. So let me remind you that we already have centers that do that, and they do this as a hobby, because systematically we have not been able to find the right place for such actions. To conclude, prevention is also something that perhaps is less spectacular, but we could call it adherence. It is about how the system should care for patients to adhere to recommendations. It is about taking drugs, but it's also about lifestyle changes. And it is not only about the level of education, but it is also about the level of enforcing specific actions by the public payer that will promote that. We can see this in cost. We can see that it already is bringing some consequences, positive consequences. Having such good experiences, we simply should expand it to some other areas, because why should we coordinate care only for the post-MI patients? And we are not supposed to do that for patients with very high cardiovascular risk. We have experiences, we have capabilities, skills, we have the models, and we also have the path forward. And I think that we will not move forward if we are not going to focus on prevention very strongly. Thank you very much. We will still talk about that system, but I have a question of Professor Banach. As Professor Chlebus says, we already have some ready-made solutions. So what can we do now here? Taking into account the fact that we are now in the presidency of the European Council, that some actions in the area of treatment of cardiovascular diseases are actually implemented to improve what we already have, but also to have a long-term approach, to look ahead and think which actions should be undertaken, the actions that will make the fight against cardiovascular diseases more effective. Thank you. Thank you for the invite. Congratulations, everyone. I think that this report is really excellent. And I hope that it can be implemented by everyone. I was wondering when you were asking the question whether I'm supposed to be a realist or a dreamer. I have always been a dreamer. But the older I get, the more realistic I become. But on a serious note, I start with grasping an opportunity today that we have the head of the health committee that is in the European Union, who also has great experience, who knows the system also in different parts of the country, Mr. Yorubas. And this is what we discussed with Professor Gill. Why finally, when we have that greatest killer, and we all identify it as a greatest killer, why not to create an independent program to finance the treatment of cardiovascular diseases similar to the oncological diseases, and it translates into specific tangible health benefits. I have to tell you that I really envy oncologists and the community of cancer patients. We have to admit that it is the patients that play the crucial role here. I also would like to congratulate diabetologists and the community fighting for better diagnostics and treatment of diabetes. Because as a matter of fact, we, from the perspective of cardiovascular diseases, starting with education, we lose fully. We had some tests with psychologists as well as sociologists what patients are afraid of. Patients are not afraid of cardiovascular diseases. Patients are afraid of cancer, and then they are afraid of diabetes. That is why the awareness of patients at different stages is getting lower and lower. That's why we have to do with the situation that even post-MI patients do not fully identify their risks, and they do not realize that within the following 3 years post-MI, every third or every fourth of these patients will die. This is what I always stress. Patients with identified diagnosed cancer and under treatment, we have 2 million of them in Poland, and this is a huge success of personalization of treatment, drugs that are tailored to specific mutations as well as their availability in Poland. We have to say this very openly. As far as MI is concerned, we have 1 million patients post-MI, and these patients are dying. They are disappearing. I don't want to say what it is like from the perspective of not allowing MI to happen. I think that we all have all the skills, all the capabilities to do this effectively. On the one hand, I don't really want to speak a lot about it because I think that it is difficult for all of us. It's about health education, which suddenly becomes political. And it used to be banal. It used to be simple. At the same time, in different countries, it translated into a huge health success, and we would have really great benefits, not immediately, but in 10 or 20 years' time, and we will have a different society. This is what was observed in Spain with CIS program, Familia program of Professor Valentina Foster. I'm very happy that Professor Gill said what he said, because from different perspectives we are revolutionaries, or we would like to be revolutionaries, but on the other hand we have to stress that in Poland we have different solutions available, and with good evaluation, validation could be combined in one specific system that would be very effective in the context of primary prevention or coordinated care in primary prevention, because the coordination 40+ program where patient is not left alone with the result but is immediately referred to the coordinated primary care, and when it is combined also with specialist care where patients can be referred for cardiological consult and patients will go back to the primary care center. And then finally the question of cardiological national network that was supposed to be implemented a long time ago, but we are not going to talk about that. Let's say something about positive sides that kind of fill some of the gaps in the cardiological patients. The national program of cardiovascular diseases, when we have lots and lots of things, but we don't have tangible results because it physically does not work. We have some elements which are connected with the standardization of some things which have been implemented, but realistically it is not operational. So when all these programs are combined, it would create a path for a patient on the one hand. On the other hand, it would create opportunities that we would have to call it coordinated care in primary prevention or the primary care, that it would be such a care. I would like that very much. We are frequently naive that we should take advantage of every period, including the presidency, but I would really like someone during the presidency to say that, well, we have some solutions. When there is a slight attempt to bring these elements together with each other, they create a real opportunity that it will not be 2% of the national healthcare budget is devoted to prevention, but much more, because then we will know that prevention is of a critical significance and we will not just talk about it. Thank you. And my question of Professor Christian Witt. You already had the cost MI that as an effective one. It turns out to be effective in MI prevention. What can be done? What can be changed? Let me go back to what Professor Bach said. I also would like to speak very positively about that. Looking at the results of studies of the Polish Cardiac Society where patients paid for 2 drugs. I don't think that now they will pay for 2 drugs because starting January, we have Novakin under reimbursement, and I think that cardiological patients do not really have to pay 100%. Well, perhaps with the exception of one group of drugs. Why are patients more afraid of cancer and diabetes, and they are afraid to a lesser extent by cardiovascular diseases? Perhaps it is the case that patients will think cardiologists will save my life. Perhaps it's about a positive message. National Recovery Plan in the area of cardiology is not signed, but it will be signed. Thanks to the fact that it will be signed a little bit later, it's going to be 2.7 billion and not 1.5 billion. It's also positive. Talking about the coordinated post-MI care. This program is really implemented in Poland starting 2018. We have a lot of scientific evidence, over 50 publications in PubMed. That coordinated post-MI care improves prognosis post-MI in patients with atrial fibrillation, cardiac failure. And we have documents that prove that it is highly effective program also for those institutions that are involved in that. We have additional indicators. The last indicator that we've been involved for the last 6 months is cos-lipid. And in these patients where it is used, we are able to keep 55 mg% if it exceeds that in 40% patients. We have an additional indicator for 10%. And it is also something that motivates. And using statins, we are able to get the ratio of 67% who are able to achieve such a good value of LDL on the treatment. This is something which is difficult to achieve in different European studies, and they show that target in 36 to 40%. We are able to do that if we pay for quality. Is it a success? Definitely, it is the success of the Polish Cardiac Society and the Agency of Assessment of Medical Technologies, as well as the Ministry. And those patients who had a chance and a luck to be in the center in case of their MI that do cause MI, but there are 100 of them, but 32% of patients are recruited every year. When we look at the 3 regions, Wielkopolskie, Dolnośląskie and Śląskie, they do over 50% of the needs under COS. We can say that in the remaining regions, the situation is quite mediocre. When we analyze the most severe patients that require bypass or those who require the implantation of high-energy devices, then in almost 50% of regions, those services are not done under COS. On the one hand, it is the success. On the other hand, it is far away. Yes. So there is a question why. I can see 2 main reasons, and I call them a problem of large centers that do not do COS-MI, and I don't know why a center knows how to sign the contract for a COS. They are prepared organizationally to do that. It requires some effort, and in my center annually there are 1,000 patients introduced to COS-MI. This number is achieved in quite many regions, and I have a coordinator who is responsible for the coordination of the whole process. It is a problem of rural Poland. Many centers that treat MIs, they are small, good, and on monthly basis they treat 40 to 50 patients with MI. But if we take good ratio of course MI 50, then we have 20 patients. If 50% of them are accepted for daily therapy, then it is just 50%. So no one is going to do that for 10 patients because it was going not to be effective. It will be highly ineffective. That is why I am convinced, and we really have to do a lot about it, and this is a request to the Polish Cardiac Society, to encourage the National Health Fund to introduce some changes in that language. I am actually not really talking about the fact that the physical therapy should not be done under COS-MI, but it must be simply made more flexible so that we could introduce a ratio of patients who do not really want to have the physical therapy because, well, they do not want to if they are young, and there are some other centers where it is not possible to build additional departments. And for example, early daily therapy should be moved to the cardiological department for that program to be done for a few days and so that it could be continued remotely for these patients. Thank you. Thank you very much, Professor. I would like to respond to that and refer to what Senator Gordon Koroń. Well, I hope that I can hear you. Yes, Senator. So which direction should we take to build the systems for the treatment of cardiovascular diseases? Which elements they should be made up of? Not to allow the effect of some second category Poland, some rural Poland. For patients from Warsaw who have provided access to treatment had the same access as people who live in small towns and villages in Poland. How to build the system, how to change it. Good morning. Thank you very much for the invitation. It is a very good question because we also have to look at it horizontally. There were many arguments presented. First of all, we simply have to use the potential that we have at our disposal. I have no doubt that in the group of such eminent experts, this system can be improved. We have a fantastic platform of which is called individual patient account, and I believe that we should aspire to increasing the number of patients, also those who live in rural areas, to use that. Recently, under the presidency, there was a meeting with the Danish delegation organized. I support the idea of not reinventing the wheel. In Denmark, they have e-health quite well organized. Their tools, for example, of early prevention, are really great. I had an idea to create a health alert. Depending on the age group, people could be encouraged to go through some screening prophylactic tests. Why there are so few people who use those screening tests? We have a 40-plus prevention. It seems that it is available. Patients can come to the primary healthcare center or different labs, but people do not know about that, and there is no feedback. There are no recommendations, there are no conclusions resulting from that test. It is unacceptable for me, especially that it is financed from public funds. I am a cardiologist myself, and I examine patients who come to me with the results of those analyses, and it is really rare that they are done for preventive causes. They are simply taken to control the pre-existing diseases, and I think that we have quite much to do here. I already know that the ministry is already working on risk factors for patients, and prevention should be introduced in asymptomatic patients in younger age groups. Not to spend later significant funds on reparative medicine. In Poland, we have high cardiovascular risk. It is true that people die of heart diseases, but I also know that there are some works underway to develop a new death certificate, death card. Very frequently, it simply shows cardiac failure, or cardiorespiratory failure, and I think that we have too many deaths due to cardiovascular diseases because we invest quite much in health, maybe not in prevention but reparative medicine, and Poland is a leader in the treatment of different coronary syndromes. The situation is quite worse as far as long-term prognosis is concerned, and here prevention and physical therapy are very important. In the Senate, with the participation of experts, we stimulated the ministry to finally introduce a program for the measurements of cholesterol in a 6-year-olds. if we meet parents and we ask how many of them check levels of cholesterol in their children, almost no one does that. But we should treat such people as early as possible, and we should treat them according to the evidence-based medicine. What about the presidency? It's a great opportunity for us because it is actually overlapping with the beginning of the new term of office of the European Parliament. Let's take advantage of this opportunity. Prevention is a priority for health, just as health safety. If we lose this opportunity, we will never be able to build a new, good preventive program for our patients. We'll live shorter lives than our neighbors in Europe, and I think that everyone should be on board. In the Senate, we want to adopt a resolution that 2025 is the year of prevention and health education. While education is failing, I am really very sorry about that, because if we do not have early school education, how are we supposed to teach health measures to our children who could convey their knowledge to their parents and grandparents? I just am sorry that politics got involved. Well, perhaps, sex education could be optional, although I don't understand that either. But as a doctor and a senator, I myself would like some of the lifestyle trends be well rooted in our children and young people, because they are our future. And we must not forget about that, especially as far as the knowledge of how little fertility we have. The safety of our country depends on health safety of people in Poland. Whenever we are talking about the battlefield medicine, well, a sick society doesn't really fight well, and our children, who are innumerous, should be very healthy to be able to participate in public and social life and not immediately get down with severe diseases that take huge spendings from the state budget. Thank you very much. I do not know whether you really understood everything what I was saying. Thank you very much, Senator. Thank you very much for what you said. Well, I have a feeling that the development of the system, effective system of treating cardiovascular diseases, is especially complex. Let me add one thing. The National Cardiological Network we are talking about, plus coordination with healthcare, which was said here. I don't really want to repeat what said. Professor Gill talked about it. We know that prevention in schools is very important. Then good contact with primary care physicians, not at the time of significant severe diseases, but in prevention, and hospital system with different levels of referential certificates that are responsible for patients who are in worse condition, and patients must not really get away from the system. It's also about money, and it's also about patients' responsibility for what they get, because they get reimbursed drugs, they get physical therapy, but they do not have full information, and patients also talk about it. They do not know where they are supposed to go, at what time. They have problem with accessibility, and we have to use modern tools, which we already have access to, but we simply have to put the puzzles together. Thank you very much. You were very correct to say that a system is required. How much is the system specialists and patients need? During our discussion, we referred frequently to health education. We will still talk about it, and we will also talk about prevention. Let me ask Professor Pawlak. What about prevention? What about prophylaxis? Because it's not the case that we do not have solutions. We have plenty of solutions. And they apply to cardiological care. We have ideas how to develop prevention, what it should be like, but something does not work here. So how to make sure that the system is getting better? Thank you for the invite. True. You ask a question, why is the situation so bad if it is so good? Whenever I reflect on this question, I ask experts, and I realize that one of the key elements is the development of trust between patients and doctors. We have plenty of different programs in Poland. One of them is 40+ program, and they are not unused. We prepare various programs. For example, the Association of Heart Failure prepared the educational program cardioline.pl. Patients come, but their numbers are lower than we expect. It's very good that we talk about prevention because it is the first step. We have to talk about prevention in a very clear way, but also very determined way. It is the first thing. And we have to talk not only about primary prevention, although I realize that it is incredibly important, but we have a huge population of cardiological patients. We are here talking about cardiovascular deaths. So we have to talk about secondary prevention, a population of heart failure patients, which is still skyrocketing from the perspective of the number of their deaths. So we can't forget about that. And I believe that one of the elements of that is the fact that in the whole network of different actions, we do not have sufficient educators. And it would be good to create a program of education, but it would be also very important for us to create those people who will be well prepared, who will be responsible for education. And these people will have to know how to reach their audience in an effective way.
So what matters is collaboration based on mutual trust and on reaching both younger and older recipients, healthy and already diseased. Another important thing is that is the way of reaching the society. We see many programs out there that are dedicated to specific units that are targeting a wide audience, but we do not see cardiology there. So we do not talk enough about the risk of cardiac death on the news, not on the mainstream media. So that information, that issue is not as discussed as it should be. And I think that's exactly where we could be able to impact public awareness of patients and healthy individuals alike. And perhaps we should also consider additional elements like cholesterol, for instance. We talk about cholesterol levels, but we know that there are new markers out there, new markers available that are independent of certain elements used to date. So maybe we should use these new elements to be able to better forecast cardiovascular risk. Perhaps we would be able to be more precise in evaluating the risk levels in our society. Thank you very much, Professor. And going back to what you just said, I would now like to ask the question of Agnieszka Wołczenko. So going back to the health education again, so why? If we are all so conscious and aware, why can't we build this system successfully? Isn't it a failure of the institutions themselves, of patient advocacy groups as well? This is an interesting question. Well, in part, yes, we might say that it's a failure on the part of the institutions and to some extent also patient advocacy groups alike, because in my opinion, it is the patient advocacy groups that have taken the most of the burden of education. So getting in touch with patients all over the country, executing all kinds of projects and initiatives, public awareness campaigns, educational campaigns. What we are missing is the support from the institutions. In terms of oncology, for instance, there was a broad media campaign in the public media outlets about cancer threat, about cancer overall. So it was talked about everywhere all the time. But when it comes to cardiac diseases, well, yes, there are certain releases on the media, some interviews, some incidental activities. So yes, it is out there, but not as intensely as it should be. In your previous presentations, we heard that Polish people are mostly scared of cancer. they are not scared of an MI. And yes, we've heard about that before. In the public awareness, there is what's encoded in the public awareness is that we have excellent specialists, we have excellent centers, we have the tools. And so if we get an MI and we get to one of those centers, we are going to survive it, and the prognosis is going to be much better than it used to be in the past. So this is our mental approach to the topic. Of course, it's not a rule, because the outcome can be different, but mentally we think, oh, it's happening quickly, it's curable, it's better than cancer. What we are missing is education, very common, very widespread education. There are many patient advocacy groups in Poland, but most of them focus on cancer, on oncology diseases. In cardiology, we've got around a dozen. Luckily, we were able to start working together, so we collaborate in various initiatives, and I am very happy that the Polish Cardiac Society, Polish Lipid Association, and other scientific associations also support us with their knowledge, with their involvement. They get involved in what we do, but our role comes from the need that we have. Patient advocacy groups are not founded in order to make money on drugs on the market. Well, at least not in our area. We do something because it's important to us. We are patients. I am a patient. Most of our organizations have been created because there was a need out there, because we had our own experience that showed us this need. So our potential is limited, and getting support from scientific societies, associations, institutions, in short, is very important for us, because then we can articulate our observations, we can tell what's important for us, and you as experts, you look at us from the different point of view. The patient can communicate his or her remarks. The patient can explain what could be better to make sure that the system works better, that it's finally working out, because we heard many sentences about those programs being out there, the programs that are working, that are effective. But as a rule, these programs, for instance, those that have been focusing on MIs, they have been out there for years. If there are such screening programs, educational programs, they are normally short-lived, short-term. So what we don't have is long-term, stable involvement with guaranteed financing and education of the society, because our mentality as Polish people, it is what it is. We know it. We are a society of tired people. We don't want to do things. So, for instance, 40+ program, why didn't it really work out? Because, first of all, we do not have that in our heads, that conviction that you have to take care of your health. We do not take responsibility for our health as patients. I'm talking on my own behalf as well. I think that is the case. I think it is what's happening. We feel that, if we go to a doctor because something is starting to happen, then the doctor is going to have a look at us and cure us miraculously. Give us a prescription, we get a drug, and that's good. Let's say we are compliant, because that's another problem. Treatment adherence is another problem. So adhering to the medical instructions. We are not patient enough. We are a lazy society. I apologize for saying it this straightforwardly, but that's the case. Thank you very much for your position. Well, health education is, of course, an element of a broader health security, but it's health security is also access to innovative treatments and clinical trials. So my question to President Gliniak: what hopes does the innovative pharmaceutical industry have for the Polish presidency, and how do you understand health-oriented security? Thank you for this question. I will start with good news. Our today's conference is happening under the patronage of the Polish Presidency, and that in itself is a marker of hope, because it shows us that this topic is on the agenda. Somebody found it important enough to talk about it. And I would like to go back to what Professor Gill said, but also what Madam Senator said. Yes, we do have a problem with planning changes to be introduced in our system. Today we are talking about cardiology, but it's a tremendous challenge because we do not have an ongoing plan, bipartisan plan, that's going to be verified using data. That's not happening. So we meet from time to time. In certain areas there are some discussions, but that requires proper people in proper place at a given time, but politics determines a lot whether these things are happening or not. And the presidency is a time when we do have a chance to show and to use it for change. Perhaps these changes are not going to be a revolution. These are not going to be fireworks, but they will move us forward. Why is it important? Because security is a topic of this presidency. So it's going to appear in all areas of life. Drug security, from our point of view, that is key. Manufacturing, security of deliveries, that's going to be cropping up in what we talk about. But let's go back to the times of COVID, to the pandemics, when it suddenly turned out that the system, that the efficiency of the system, its general capacity, and the general health condition of our population is extremely important, because that was an extraordinary situation. We had a tremendous burden on the system, but it also showed us that there are so many challenges to come. This report talks about exclusion of some patients. In the disease entities that we talk about, what we need is an intervention here and now, this minute. Sometimes when we think that, in some places, reaching a doctor takes days. If a patient lives somewhere on the eastern border, reaching a city, reaching a specialist is very difficult. And these elements are going to impact the efficacy of the system. Professor Banach today reminded us of some numbers. We are talking about millions. And we are talking about MIs and oncology. So these are not all the patients out there. We are talking about high percentages of the population of our country. And when we start to calculate that, recalculate that into cost, we hardly ever view that from this point of view. If you summarize all the patients who are dealing with some diseases that prevent them to live a normal life, to work, to participate in our economy, to participate in our state. We are talking about a gigantic challenge. Let me remind you that only in oncology, the WHO forecasts the incidence of cancers that is going to increase by 75% very soon. And in cardiac diseases, it's going to be similar because the risk factors are very similar. So prevention, luckily, is the element of our presidency. It is one of the priorities indicated by our government. And it seems to be an absolute key, because there is no healthcare system that could be able to handle such increases and such burdens, which is why education, educating young people, but also early diagnosis, opening the doors. We were talking about 40-plus program, but also HOOP was another program that could potentially be improved. It could be streamlined. It could be made more effective. So here the problem lies on the side of the medical community. The medical community needs to induce the interest of the patient. Maybe if we approach it from two sides, it's going to be more successful. From our perspective, what's important is to increase access to novel therapies. That is definitely a clue, but also, increasing that in terms of decision-making. So assigning resources for new agents that could be available to new patients, innovative therapies, but also to make sure that these therapies are implemented in a correctly dispersed manner so that patients can use diagnostics first, because we are talking about medications that are very advanced. They are targeting very narrow populations often. So they require molecular diagnosis. Without that, these medications will not be administered. And that is obvious, but what we focus on is another element that also coincides with our presidency, namely the beginning of the new term of the European Commission and the Draghi report that clearly points out the challenges when it comes to competitiveness of Europe. To us, well, we mean an impulse to work on the new, novel, innovative therapies and to make sure that patients also in Poland can take part in clinical trials. And these trials, they have a benefit of earlier administration of a medication, but they are also an impulse to change a system because every novel therapy means also novel diagnostics. That means education for everyone involved. And as a result, when the new agent is being introduced and available to all the patient, these therapies are more broadly utilized. So, of course, we have a pleasure co-participating in the creation of this report. And what we point out is that we are supposed to deliver you tools. We want to deliver you effective tools, efficient tools, and we hope for the Polish government and other European governments to remember that if science is created in Europe, we have access to it more quickly and our experts are better prepared. Thank you. I know we are dramatically delayed by now. My apologies. Could I just say one more thing? Just one sentence, okay? Because I still have some questions about accessibility and prevention. That should be not only focused on screening and prevention, but also prevention in the sense of administering various kinds of medications that prevent the situation getting more severe. And not only in the form of drug programs, but in the form of broad accessibility. Both professors, well, everyone really mentioned that. So that's our remark as a patient advocacy group. And I would like to invite you, if I may, to Thursday. This Thursday, there's going to be a presentation of what we do to show how much we need prevention, access to treatment, in order to prevent, well, we want to show you how it's happening in Europe. How can we do things early on? And my two final questions. We established with, well, first a question to Mariusz Kognitowski, who's one of the co-authors of the report. What other than financing? Because, of course, money is key. Also, continuity of financing is important, especially when it comes to prevention, diagnosis, and treatment of cardiac diseases. But what, other than financing, would make an effective system easier to create? Well, of course, we know that money is not everything, but long ago I read that $1 spent on prevention is $10 less than spent on treatment. I am not sure if these numbers are correct, but it shows the direction that I think we should take. So to redistribute or reallocate some resources and increasing the expenditure on raising awareness, on prevention, on prophylaxis, on health education. I know that this is a controversial statement because if it's a sum-zero game, we have to take money away from someone. But let's hope that's not going to be the case. I hope that we will hear in a moment that this sum-zero game is not a challenge. Yes, thank you. And a final question to Director Korbinski. We were listening and talking about what works, what doesn't, what are the recommendations, what are the challenges. So which of those recommendations could be implemented? What are you working on now at the ministry when it comes to cardiovascular diseases, of course? Thank you. I have a question first. How much time do I have? Because I'm the last to speak. Well, we don't have time. We don't have time, but we will create time for you. Yes, that's the atmosphere we are working in on a daily basis, the atmosphere of nothing. Well, thank you, first of all, for having me. I'm very glad that this report was created. It's a shame it was not published 2 months before. It would probably be included in the justification for the legal act on the National Cardiology Network, because it does refer to what this network is going to introduce. And it's not just structure and coordination. It also introduces certain tools allowing us to generate and providing cardiology care to patients who were screened in screening programs, and also patients who have a primary diagnosis offered. They will get a cardiology diagnosis card, and they will enter a cardiology network where they will be taken care of. So these are the things that we can do. We can improve coordination. We can improve the structure of the network, coordination of cardiology care. What we also can do is to make sure that the collaboration with primary care is further developed. So specialists and hospitals should work better with primary care physicians, not only at the beginning, so when the patient starts cardiology care, but also after specialized treatment elsewhere. And this is something that we haven't mentioned, and it's a tremendous problem of the Polish system. Namely, patients at some point, they are going to a specialist, or they are being lost to follow-up after they finalize a certain stage of treatment. And this entire expensive process of treatment is, in a sense, lost. Zawał program was so successful because it kept tabs on the patient. So just very shortly, what I wanted to say is that we have one major challenge: prevention and prophylaxis. We hardly ever talk about awareness, education. The brutal truth is that life revolves around money. Money is essential. It impacts our decision-making. If the Polish state, the Polish budget, wanted to support the development of internet, it introduced a tax relief on internet. If the EU wanted to support the recycling of plastic bottles, it introduces the law that's going to allow you to get a sort of a financial incentive for recycling. And this is what's missing from this discussion, because everything about coordination, the system, that can be introduced. These are relatively simple changes. Of course, technologically, it's not always as simple as that, but it can be done. What we are missing from the public discussion, because it is a political thing as well, binding prevention to financing and to financial outcomes. So not just securing finances for it within the National Health Fund, but also creating patient awareness when it comes to the essence of prevention via financial outcome, because that's the simplest thing that we can do as a state, as a public payer. I think that this is what we are facing now. Of course, it's going to be very difficult because in the short-term perspective, it's going to impact the finances that we have available for healthcare. But in the long-term, 3-5-year-long perspective, it's an investment. I encourage you, the various organizations and the medical community, to build this main element when we talk about prevention. Let's combine it with a financial incentive, because we can finance 4, 5, 10 programs. We can create IT solutions, but still there's going to be a problem that we see when it comes to prevention in Poland. Namely, we are one of the countries with the lowest index of patients joining preventive programs, despite investing quite significant resources into it. We do invest quite a lot of money in raising awareness, in education. The same goes for oncology, but we are still hitting the wall of very low presence of patients. Even if, when the patient enrolls, then we can do what we are supposed to do, coordinate care. But I think we are all speaking with the same voice. As a ministry, we are very much in favor of making prevention the main engine of improving cardiology care in Poland. Thank you very much. Thank you, Director, for summarizing this discussion. Let me just remind you who participated in this panel. Professor Robert Gil, Maciej Panek, Professor Agnieszka Pawlak, Professor Krzysztof Wita, MEP Adam Jarubas, Konrad Korbiński, Agnieszka Wołczenko, Michał Dymniak, and Mariusz Ignatowicz. Thank you very much, ladies and gentlemen. And let me now invite Michał Dobrołowicz, who's going to conduct the next panel devoted to prevention and health security. Thank you very much. Thank you, Dominika. Thank you to all of you. Thank you for this first part of the panel. We are about to start part 2. It's going to be slightly different, even though certain subjects will be continued. In a moment, we will hear whether the broadcast of part 2 has already started. But before we start, let me confirm that Dr. Agnieszka Gorgon-Komor is going to be with us. Madam Senator, I'm so glad that you have not disconnected, that you are staying with us for the second part of the debate. So thank you, Senator, for that. Let's use the time that we have, the hour ahead of us. So now, Dr. Gałązka-Sobotka, please take your seat. This debate is going to be joined by Dr. Paweł Koczkodaj from the National Institute of Oncology. We will be joined by Justyna Mieszalska, head of the Medical Center of the Warsaw Medical University. Justyna Mieszalska is also a former head of the Department of Public Health in the Ministry of Health, so her perspective is also going to be useful. Monika Kaczmarek is also with us from the Association of Diabetology Patients. We are very happy also to hear from Georg Schreffenfuchs, representing Novartis. So thank you very much for being with us. Ladies and gentlemen, like I said, we have 60 minutes. We will do our best to use this time as best as we can to make sure that your presence is used to the maximum. We've got time until, well, 12:45, let's say. So let me take a seat. Director Byliniak talked about the pandemics, talked about COVID pandemic. 5 years ago, it was January 24th, and that's when the first confirmed COVID case happened in France, in Europe. What happened next, we all remember, and this time of the Polish Presidency is also going to mark a 5-year anniversary of COVID. We talked about the diseases, cardiology diseases, patients with high cardiovascular risk, patients with dyslipidemia, hypercholesterolemia. These are the patients who are also at risk of many other comorbidities. They have obesity, patients with nicotine addiction, smokers, basically, patients with diabetes or in pre-diabetic state. We will be talking about them as well. Patients with multiple comorbidities and risk factors. So in this panel, we want to tell you about those campaigns, those preventive measures that are working out, or those elements that have brought some outcomes. So what can we learn from them? What conclusions can be drawn? And how can we plan it all together? So your perspective is going to be definitely very valuable for us. Let's start with obesity. Over to Dr. Gałązka-Sobotka. Doctor, much is being said about obesity, also on the media. As journalists, we discuss it often, and we often hear that it's not just a cosmetic problem. It's a severe disease, bringing with it a risk of many complications. So obesity being overweight. So from your perspective, what works? What elements are effective? And they are working out well for the prophylaxis. Hello, everyone. Thank you for having me. Thank you for this initiative and a very interesting report. And thank you for this question, because it seems that, thank you for starting with obesity. It's not by accident that obesity is called a mother of all diseases. When we have a look at the spectrum of complications generated by obesity developing before us, before our eyes. It's a disease that continued for many decades in the Polish system as a completely transparent disease. We were just not noticing it at all. We often talked about patients with cardiac disorders, diabetes, nephrology diseases, patients present in our orthopedic wards as well, had multiple complications in their skeletal system, but we failed to notice the primary cause, the disease that stood behind all those complications. Not only we did not see it in public statistics because E66 codes appears in primary care several 100,000 times in our system, and we know from epidemiology studies that obesity in Poland affects 9 million people. Overweight, well, over 50% of our society is overweight, and the dynamics of the development of this problem among Polish children is one of the highest in Europe. And all that is happening before our eyes, and it shows us that the system as a whole seems to be not systematic enough, because a system is a combination of collaborating elements, reacting to one another, integrated with one another, and able to create some added value. The added value in healthcare is health. And if we live shorter than our European counterparts, if we have a shorter professional activity because of health. If our children, even now at school, 20% of them develop hypertension, a lot of them obesity and mental health problems. That means that what we call system in our debate is not really a system.
And I think that in the discussion about obesity, we should go a little bit higher and have a helicopter view to see everything that we create and what we discuss. Can I please ask you to show a slide? And it's also important to build a concept of a state that is again focused on these things anew, because what we need today is the change from a state that is disease-focused. Now we spend a lot on diagnosis and treatment, but usually advanced diseases. But at the same time, we do not understand a mechanism of health care, prevention, protection, because here we are talking about the coexistence of different factors and different stakeholders. They have to see their role, their action, their contribution to the provision that we as citizens are more focused on a responsible attitude to our health. No one really has such an attitude, no one. We have not really neglected anyone from that map. Everyone that's sitting here, every representative of different state institutions, local government, the world of business, education, everyone is here on the map of public health. And that means that all of us have a task. All of us have a specific role that we have to play. Minister of Infrastructure should sit with us and talk how to create guidelines today for construction, physical development, as well as the structure of buildings architecture, so that the environment could be conducive to spontaneous movement, to make sure that our children will get out of cars and start cycling to schools. We also have to talk with the Minister of Agriculture to build a strategy for the development of healthy food production in Poland, because we need to change the proportions of a shelf in store where one cupboard is healthy food and 99% of the whole space is devoted to highly processed food. What kind of food is it that? And then we will also have to change our focus on different subsystems of the state, and then we are able to create circumstances for everything that creates our behavior had the health-promoting nature and not disease-promoting nature. The number of stores that have license to sell alcohol, they create a very pathogenic living environment. We have to change it. Education is only one of the elements. Education is important, I agree, but if we create so many factors that are unconducive to the right health-related behavior, well, the majority of us work in modern office buildings, we can't use stairs. And using the stairs is the simplest way to improve the fitness, to work on our cardiovascular system. So in the civilizational progress, in our chasing after civilizational benefits, we do not reflect on how to properly consume them. Today, that created the generation of obesity. So in our family, in our school, in our yard, in our public policies, in our employers, they frequently do not have any tools to build a health awareness of employees. All these things influenced the development of the epidemic of obesity, which translated onto the epidemic of cardiovascular diseases, diabetes, etc., etc. So if we really want to change it, and this is the right moment, this is the presidency in the European Council, you talk about the presidency. To tell you the truth, for the last 2 years, there was the partnership for the reduction and prevention of obesity was created, and it gathered different social organizations, employers organizations, businesses, scientific societies. We all get together today because we know that perhaps for the coming 6 months of the presidency, we will have to decide about the redefinition of the state's policy, because the state has to get out of that wrong focus on the environment that generates diseases. We simply have to create the standards of a healthy school. We have to create guidelines for the development of infrastructure that will be conducive to physical activity, fitness. Healthy school is the school that develops healthy habits automatically, yes. And this is not just a campaign that is stimulated by a foundation or an expression of activity and responsibility of individuals. Because our children deserve that. They deserve to develop in a healthy environment. We also deserve to have a perspective of a society that will keep our continuity and will provide for the future positive social and economic development. When we look at the condition of our children today, we know that we should perhaps start with the children, and we should build this new paradigm of the state, especially focusing on the youngest generation, because there are fewer and fewer of them. We know what our fertility is, and if we allow the exposure of risk factors to the youngest generation to be so huge, then as a matter of fact, we accept the loss of the most valuable capital, which is the health capital of those who in a moment are going to enter the labor market. So this is really an exceptional moment. And here we could carry this discussion up to the European Forum. This is the challenge which is faced by the whole European continent, and not only Poland. There are many countries that face a problem of obesity, and many countries are looking for some ideas what to do to make it more effective. And when we review different global solutions, we realize that only holistic, comprehensive, intersectoral activities that engage all the communities can be successful to fight one of the most dangerous civilizational diseases. And now let me go back to the question about the most effective methods that we are not reaching for. The most effective method to change eating habits for everyone is universal access to drinking water in public places. We could do so much. We could invest in the taps for drinking water, musea, bus stations, railway stations, places where we go to in our everyday life, and it would already show to us how the consumption would change from the perspective of the consumption of water. And this is also a habit of just hydration, perhaps also at schools. You said that there are fewer and fewer children being born. We have data, the latest data from the Chief Statistical Office published in the morning, and it shows that the past November of 2024 was a month where the lowest number of children was born in Poland since the Second World War. 18,000 children for the whole country in 1 month. Whenever you are talking about healthy school, it's also about a health education. During the first debate, it was also one of the subjects of the debate. But going away from politics, I understand that healthy school is not only about education about health, talking about it, but organizing that school to develop habits. For example, drinking water that is available, and a child would go there throughout the whole day and not during the physical exercises class. Yes, healthy school is about the environment of children's life. This is the change about eating habits. When we look at the Japanese population or the Scandinavian people who are able to get a success to reduce obesity amongst children, you can see that children are not fed by being served a plate with food by a kitchen employee, but we simply create a culture of experiencing nutrition. How an important element of life is nutrition. This is a culture in which lunch break is time for the whole school, and this is the place where the relationships are built between the students, where in the quiet environment you can eat some meal you can pick up. It is not served. A child has the right to pick up what they want to eat. Well, there is always, it must always be healthy. The most important rule of those solutions is that, first of all, children do not bring anything to schools. So we solve a problem of economic inequalities, because many children do not bring anything to schools because their parents can't afford it. All the children eat snacks at school and lunch at school, and they eat what is healthy. And this is the advantage that we might have. We use intervention of a universal nature. Secondly, it would do away with the inequalities connected with access. And three, it would solve also many other problems, and not only feeding your child, because we have to remember that table is the place where you build social relations, and building social relations as well as the peer relationships, which is stimulated, controlled peer relationships. It is an excellent tool for education. A class devoted to health is just one of the elements. We simply have to experience education. We have experienced it in such a way that science classes can be organized outside and not necessarily in a classroom, that we can have a totally different approach to to exercises, something that would build some pleasure of physical activity and not a nasty experience and embarrassing circumstance for quite many children of some artificial and forced competition, which for many of the children is a stress factor. We have to look differently of some rituals. Let me use this word, rituals. We have to get out of those patterns which are not effective. And finally, what is good is that these models are being developed in Polish schools. I know local governments, Rybnik, Leżajsk, where at the local government level, the mindset was changed by means of changing the role of the local government and the image of public school. Different mechanisms and models from Scandinavia were introduced, from Sweden were introduced, and the results here are really great. And they are connected with the number of children who want to eat at school, the amount of vegetables they eat, and also decreasing different social frictions and tensions between the communities of children. And they constitute evidence that such interventions are really effective. I just dream of one thing. They must not be practiced only by some responsible, enlightened local governments and heads that go outside of the box. It must simply become something normal, something which is universal, which we call a systemic solution. Yeah, this is why we are having this panel, how to use the potential. The potential is available, but what to do to use it to a greater extent. We have Senator Agnieszka Gorgoń-Komor with us. So, Senator, I have two questions. Since we are here talking about children, well, we can see you very well, and we can also hear you very well. So let me first go back to the 6-year-olds medical examination as well as lipidogram. And there are questions whether lipidogram is already introduced to those screening tests for children. We know that Agency of Medical Technologies and Tariffs has been involved in the evaluation of that for a few months. What is the plan, and what do you plan to do in the coming months in the Polish Senate? What can we expect?
Dziękuję za zaproszenie.
Thank you again for the invite.
To już mój drugi panel. Oczywiście
It is already the
dobrze, że
second panel.
pan poseł
I
Miśkiewicz
talked
współpracując z
about it. It
Fundacją
was mentioned at the
Polityki,
beginning of the term of office in the Senate.
wprowadziła nas taką wiedzę,
Senator
którą
Myśliwiec
nazywa
really
wielką
introduced to
wiedzą
us the information how important it is. We realized that parents and medical communities do not analyze lipids in little children. If it was mandatory, we would be able to identify familial hyperlipidemia, and Professor Bana always talks about it, and this is an important subject. Then we would be able to avoid mortality
wiekowej,
in young people, 30 plus, 40 plus, sometimes even 20 plus.
genetyczne
Because this is a genetic
naszych
defect, and these people very
Ja
early get acute coronary syndromes.
innowacji w medycynie zobaczyłam, jak
Leading a team of medical innovation, I saw how it is done in Europe. For the last 8 years, Poland is a country where this problem was not touched at all. But experts felt that it really is an incredibly important issue. So I'm very happy that the ministry started their work. I realized that it has to go through the whole path of the procedures. I have the promise from the ministry that it will be done. I hope that it will be implemented this year, but I am not able to tell you exactly when. But definitely, I'm very much interested in the subject, especially that the Polish Senate is a place where the subject was actually
temat bardzo nietypowy, który wyprowadza się do
presented, and we start to work on it. And what about the Senate? I understand that this is the year of prevention in the Senate. Yes, prevention.
przepraszam, bo słyszę siebie też.
Sorry, because I can hear myself.
Przez cały 2024
Throughout 2024, we were getting prepared for 2025, hoping that health education will become one of the subjects at school. But unfortunately, due to politics,
miały przestrzeni publicznej, że ten przedmiot nie będzie obowiązkowy.
it is not going to be mandatory. And we know how children learn. If a class is not mandatory, they will choose not to attend it. But we as experts see how important it is, because children are able to absorb lots and lots of knowledge. We do not really them to learn from different internet portals and social media. The content in online is frequently deprived of scientific basis, and it may have negative impact on what children are taught. It does not only apply to children, it also applies to the adults. We as practitioners, medical practitioners, we have to tackle with those paramedical content, and we have to do something with that. I believe that it is due to the misinformation online. We have a greater incidence rate of different diseases. We have to care for our children. As Dr. Gałązka-Sobotka said, the mutual relations, eating together, what we choose, this is something very important. We want to get rid of the influence of processed food. On the other hand, we still have not enough money in the state budget, and the balance that should be kept is to be decided by different decision makers at the legislative level or sometimes at the executive level. But finally, we have to stop talking about it. We have to do it. The money devoted to prevention must be guaranteed because it is guaranteed already in the sugar tax. But prevention is not always implemented the way it should be. The results of the prevention would be visible in our children and in our grandchildren. I realize that those outcomes will not be visible overnight, but we have to do this because we have lower fertility. We do not have enough money for the good reparative medicine. As senator, I always get some interventions to support the different money collections of people because they do not have enough money to buy some drug. We also have to think about different drug programs. Which drugs should be used in regular medical situation and be fully reimbursed to actually correct the treatment as well as secondary prevention. And another thing is about vaccinations. What is happening here, it is actually totally depressing. We see on TV, for example, how emergency departments in hospitals are overcrowded because people get influenza. We have 30-year-olds dying because we get influenza, and well, even. I mean, we simply do not vaccinate. If we buy vaccines, then we don't have to buy drugs to treat the disease, and the drugs will always be more expensive than just paying for a vaccine. But the anti-vaxxers create huge misinformation online. What our grandmothers, our aunts, who are not really well educated, what they did in the past, and we were able to actually get down with many diseases. Those diseases come back now. I am a medical doctor. I do not know how to solve it. There is this white paper of doctors who support vaccinations, but in the medical community there are also those who do not support vaccinations. But I believe that the education of medical personnel should actually introduce the mandatory evidence-based medicine, and the importance of vaccinations in prevention is huge. It is HPV, seasonal diseases, COVID. I think that we lost our capacity. I don't really want to talk about what we lost, what is bad, but we also have to talk about that. During the COVID period, we learned how to wash hands. Many diseases are transmitted through our dirty hands. When we go to different public institution stores, we can see that those dosing machines are empty or even dusty. When we want to disinfect our hands, they are simply empty. This is a terrible loss for me, a terrible loss of what we were able to develop during the pandemic. Because we are here talking about what the pandemic actually destroyed, but we also learned a lot from the pandemic. I know that we lost many people, but we are a little bit stronger through that experience. As a doctor, what I see in the pandemic is quite destructive when I realize that people get more alienated, for example, in the medical community. We experienced something that was very difficult, something that was terrible. Many people died, also representatives of the medical community. And now, when everyone is forgetting the pandemic because it is not en vogue anymore, it simply deprives us of energy to fight for more knowledge, better prevention. Well, I know that we talk about it, but it's very difficult to implement it. But we all have to get involved about it. We talk about obesity, which is the plague today, and I'm very happy that we were able to show obesity in the Senate to show patients who actually had to tackle the disease, not only physically, but also mentally, who had to experience depression. They felt too fat. Sorry for using that word. They felt too fat. It is not a problem of increasing weight, but it is connected not with beauty. It is a problem of different metabolic changes, as well as social alienation or mental changes that are connected with that. It is a very complex disease, and I am very happy that we are going to talk here about the treating of the causes of the disease. We will do this in the team that was established by Izabela Leszczyna, or in different expert meetings, as well as during the meetings of the innovation in medicine team, which I am a chair of. And I believe that the presidency is the right time when we can do so much, because we are starting the new term of office of the Parliament. The presence of a member of the European Parliament, Jarubas, testifies to the fact that we are even better positioned to use the capacity for the sake of our patients to protect health and not only to treat the diseases. Thank you. Thank you very much, Senator. And I think that as far as COVID is concerned, our presidency is also the time when we will talk a little more about the pandemic, although I realize that many people want to forget it. But the 5th anniversary of the pandemic that is coming in a few weeks' time is going to be a time of reflection, not only in the media, to think about what we learned and which conclusions we drew. And I am trying to think about the combination of the postulates of Senator Agnieszka Gorgoń-Komor as well as Dr. Małgorzata Gałązka-Sobotka. If in those places where there are containers for disinfectants to be replaced by the full ones, as well as together with some water taps where you are able to hydrate as well as wash your hands, disinfect your hands, just to remember what happened, to remember best practices. We talk about best practices. I'm also looking at the president of the board of the Medical Center of Warsaw Medical University, Justyna Mieszalska, who was the director of the Department of Public Health in the Ministry of Health for years. Well, we are now looking for a good idea for a prevention program. We know that this year is going to bring changes. The changes are being announced by the Ministry of Health because the program of Prevention 40 Plus, which is also referred to in the report we are talking about, is also devoted to. This program is to be in place until the end of April, but then it is going to be replaced by a new program, My Health. This is how it is going to be named. It is going to provide not only tests but also medical consult, if those tests are concerning. I know that there are some changes in the occupational medicine. How do you look at it as a former director in the Ministry of Health and now a person who is responsible for the preparation of preventive programs? How to plan a program to make it more effective? Thank you. Thank you very much for the invite. It is really a pleasure for me that I can here speak in my double capacity. First of all, I fully agree with what Dr. Gałązka-Sobotka said, as well as what the senator said. It doesn't happen frequently that I can agree with absolutely everything they say when they said that we should simply do that. But now, let me go back to the question. If we were to replace those containers, add some liquid, some disinfectant, plus put water. I remember that in my place there is just one container which is empty, which is out of order, and there is a sticker out of order, and it simply occupies some room. Yes. Water distributors, we have one per floor in our clinic. When I look at the invoices, I don't think that they are frequently used because we do not supply lots and lots of water there. It is simply there, no one uses it. So I don't think that people have a habit of drinking water. The adults don't have that habit. I am just looking around. I don't think that anyone used water, although we have water. Children, well, if you need water, let me know, and we will give it to you. Well, the glasses are clean, so we can drink it ourselves. I believe that children have a more developed habit to drink water, but everything is down to education. Now I'm thinking about health classes. Years ago, when I worked in the Ministry of Health, I was also thinking about that. It was supposed to be organized differently. When I talk with parents, however, I can see one issue. Well, obviously, I definitely support those health classes to talk about prevention, to implement it, and not to make, well, great, excellent. We are doing that, not talking, we are doing that. Please, look at him, look at you. I'm very happy to see that. So it must not be only 1 hour in health classes, and we do not really know who is going to teach that, because I think that those potential teachers are not really prepared to teach it. I guess that we still have some people who graduated from public health, and I think that those would be prepared to run such classes, but there is a problem that I don't think that such people are not allowed to enter schools to run such classes. On the other hand, there is also another problem where a child is so happy to learn. A child is like a sponge that absorbs water, is greedy for knowledge, and the child will know that it is better to use fish and not red meat, and will go to a store with the mom, and mom says, fine, but I can't really afford it, so let's take whatever we take, usually. And then there's dissonance. And that perception of 1 hour for health and education by a child will also have impact on that child's future health choices. I know that we have to shape those choices from early age. Why there are fewer children who have health problems in France? Because they have different health habits, they have different eating habits. I know that it's difficult to shape them, and I don't think that any of the prevention programs implemented by the ministry, and I worked in the ministry for 20 years, I don't think that a single one of them was successful in any way. These programs always are just one-off programs, prepared for 1 year only, for one financial year, or for the term of office of one government. Well, there are programs, of course, that are called the same name, and they seem to be repetitive, and they are going to last for 4 or 5 years, but they are not really enforced properly by many people. We simply choose one or two, and usually it is a large institution, and usually this institution is subordinated to the Ministry of Health. And those patients' organizations somehow are disappearing from the picture, while it is the patients' organizations that would be able to reach greater numbers of people, and they know who to reach in their communities. I don't really want to belittle the role of the State Hygiene Institute or the Center for Oncology. Well, it's not really the point. I don't want to do that. But I believe that these programs should be addressed to different non-governmental organizations that in that reverse pyramid of services could also participate. That reverse pyramid, in the understanding of the Ministry of Health, is the transformation from hospital treatment to different hospital-based institutions and not going out of the hospital. And I think that my thinking for the time being is doomed to fail, because I don't think that it is what it is going to look like in the understanding of our decision makers. So this is the first thing. The second thing is that a person who is responsible for the implementation of the prevention programs today, and a person who designs these programs in my institution, and we have, for example, large primary care clinic. We have like 1,000 doctors on board with us. And it seems that the potential, the capacity here is really huge. There are so many patients, and the will to participate in the 40+ program, 1 person per month. Although there were some incentives, there were rewards.
Yes, there were many incentives, and I would say, well, financial incentives devalued, really, because the employee who gets that money for coordination got used to this permanent element of their salary. So whether they do encourage or not, that 800 zlotys is still getting in their pocket. I was thinking about incentives for the patients. Yes, that's right, and we were supposed to have them, but for some reason they just didn't work out. I remember there was a moment 2 years ago when they were in place. It was about vaccinations, there were scooters, all kinds of fitness equipment, or so, but it didn't work out. But I think that would have been perfect, yes. What I've noticed, well, we have a stand for bicycles. It's always empty in front of our clinic. You know, doctors, nurses, yes, they do come, they arrive on bikes, but patients never. But I'm not really surprised, because when you're going to a hospital, you're not really in good shape normally, so maybe no wonder. Or, well, maybe if somebody came for preventive diagnostics, then that would be, you know, a bicycle or a scooter would be definitely a way to go. Yes, of course, but for a year, last year, we were preparing for this year, when we are hoping to initiate a program called Blue Primary Care Facility. For a year, we tried to gather doctors to fill out a questionnaire, answering a question. How should your employer support your health condition? Would you like for your employer to purchase, let's say, a specific diet for you to get it in boxes? Or should you like to have some classes, additional classes? And I sent this questionnaire to 1,000 people, 30 responded. 30 in 1,000. So on this side, you know, you don't really see much willingness, much involvement either. Filling out a questionnaire took maybe, I don't know, 45 seconds. So it wasn't a very long one. It could do it on your phone. You could do it on your computer. Fill it out in paper form, whatever. But we still didn't have much of a response rate. The idea was to reach the patients as well. And patients did it the following way. I would like to have more access to prevention, meaning ultrasound, echo, ECG. That's what they listed. That's it. That's everything. And well, we also take part in coordinated care. In cardiology, for instance, it includes a consult, doctor to doctor, doctor to patient, and there could be a diabetology or dietitian's consultation as well. People don't really go to dietitians. No willingness there. I would even say that they are very unwilling because they think, oh, come on, it's just a loss of time. They're going to tell me that I need to lose weight. How am I supposed to lose weight if everyone tells me that I am supposed to lose weight? I'm sick of hearing that. I don't know how to do that, where to go, what to do. So I say, well, you can do this or that. You can go to a physiotherapist, a personal trainer, to go and swimming. But you have to come here, you know? So there are so many internal barriers. First, we have to deal with those. January is a moment when we all have New Year resolutions. The fitness centers are full. I actually saw our pool that was also full, but yesterday empty already. You know, the people are withdrawing already. So once again, plenty of room to spare. The same for Pilates classes. Only 4 people yesterday. A week ago, 40. And it's still January. Yes, it's still January. And yet, so I think it's also about taking responsibility for your own health. I think we mostly think that state is responsible for our health. Yes, and let's put a full stop here, because I'm curious of the comment of our guest representing Novartis. I will ask you a question in Polish because that's the language of our meeting. I know you are getting interpretation. So I would like your comment, a short answer to the question, what is the perspective from the European point of view? What can we do? What can we change to get rid of those internal barriers that we have in ourselves? So over to you.
Thank you very much also for inviting me to this panel discussion. For me, it's really interesting now, after 14 years, where I had the pleasure to live for 1 year in Warsaw, coming back also to Warsaw. It's my second day, and I can see a huge change everywhere within the country. Well, what was really interesting for me, also listening to the previous panel discussion, there was a lot of focus 14 years about cancer, beating cancer plans. And I remember where focus were put behind, then also energy flow behind, also resources flow behind. And I think this is now really needed also for the current presidency, where prevention is the main focus. How can we put everything also behind cardiovascular disease? It's the main cause of mortality. Just to translate also the numbers, every day 5,000 people in the European Union are dying due to cardiovascular diseases. And if you translate it, just to make it as a picture, it means roughly 10 jumbo jets are falling out of the sky. And no one is really talking about it. And I think this is where we have to focus behind. And if I just think it's the biggest driver of mortality, it's also the biggest reason of disability in Europe as well as also in Poland. And if you think about ASCVD, if you just reduce by 1 millimole liter the bad cholesterol, LDL-C, you can reduce all the cardiovascular events already by 22%, treating to targets. I think people are not really aware also about their targets, where they should be. And the second topic is, we talked about also about prevention. And I think also here it's about secondary prevention, because people who have already cardiovascular events, they have the highest risk of death. And I think this is also what we can avoid, also with good prevention programs for secondary prevention. And then heart health in general, how often do we check also heart health for all the citizens within Europe? I think these programs are really needed to really focus on, because we are talking about health security. I think these are biggest causes to really guarantee health security also for the future. And I can just say, there are also good examples already in Poland. Yeah? My people just explained me also the program of Polish managed care in acute myocardial infarction. These programs are existing. I think people who are participating in these programs has a positive effect of 40% reducing events. But not enough people are really aware. Not in all the centers these programs are rolled out. And I think this is where we have to focus on. And the presidency for the next 6 months can be a good platform to really drive it.
To jeszcze jedno pytanie. Gdybym
One more question. If I could ask you to finish this sentence, what is one thing that we can learn from good European experiences, one thing that we should take over, instantly take over and do it in Poland, if you were to choose just one thing?
It's really about secondary prevention, because these are the highest risk patients, and there to drive really good programs and to spend also time and energy focusing on it.
Bardzo dziękuję. Thank you very much.
Thank you very much. And over to our panelists, if you could please comment. Monika Kaczmarek, what would patients, diabetology patients, expect? Patients with diabetes, and what has already worked, and what could happen in the future? Over to you. Yes, thank you for having me. First of all, I would like to mention something that hasn't been mentioned as yet, namely prevention, but long-term prevention. It shouldn't be just a one-off campaign. It shouldn't be a year-long or 2 years long program. It should be implemented in the form of a many-year program. In implementation of prevention, perhaps it's not going to bring us instant outcomes, but in the long-term perspective, it's going to bring fruit. Whether it's about obesity or physical activity classes or testing, I'm very glad for what Madam Senator about what Madam Senator said, and lipidogram in the 6-year-old's checkup. I think it's an excellent idea because, as we know, we will be able to draw blood during that checkup. I represent the Association of Polish Diabetes Patients, and I hope that other than lipidogram, we could also try to detect type 1 diabetes during that same blood test. That would be just one drawing of blood, one blood sample, but we could do a number of things. We could check all kinds of things, because we are talking about heart, kidney, metabolic syndrome. So all these things are running together. It's a single patient, yes, and the patient wants to feel taken care of in a comprehensive manner. The patient wants to feel safe. Not every patient needs to know everything when it comes to the rules of reimbursement and how all that happens. The patient has the right to ask a question, why me? And we have to be clear about that. We have a patient, let's say, with many comorbidities. And there are also some patients who, unfortunately, have no access or have limited access to reimbursement of state-of-the-art therapies. And they ask why. Why is that my problem? We know that administering modern treatment at an early stage of the disease prevents complications. If we are talking about complications, so let's remember that there is a number of patients who are still professionally active, and we have to realize that we don't only want to treat them. We want them to live in a relatively good condition without complications. These are people who are still facing 20 or 30 years of professional activity. They want to be professionally active. They want to be active in the labor market. They don't want to generate social costs. So if we can do that, we've got state-of-the-art therapies now. Like I said, some patients do not get reimbursement for them. They ask us why. They ask us, why can't they get the best treatment? They don't understand it. So we have to create this option for them, option for the physicians as well, to have equal access to medications. We cannot just say that this group or that group is going to get that. I know we cannot do everything at the same time. We are patient, we are, but numbers speak for themselves. If, according to International Diabetes Federation in Europe, we've got over 61 million patients with diabetes. In Poland, over 3 million. or pre-diabetic state. No, I'm talking about diabetes. Other than that, there is a population with pre-diabetic state and patients who have not been diagnosed. That is millions. If we add comorbidities, so the heart, kidney, metabolic syndrome, these are millions still, and we can prevent all that. Why not implement it at an early stage? We are talking about prevention, prophylaxis, but let's start with very small steps. I dare say that even when we are talking about state-of-the-art drugs, Poland and Slovakia are among the countries where these treatments have limited reimbursement, only in third-line treatment. Why not first line? Why not second? Let's give a chance to our patients. Let's give patients and doctors a choice. So that patients don't feel that there are some who are better and some who are worse. Much can be changed in the future. So in short, you count on a plan. You said not everything can be done at the same time, but we want to know what's going to happen in a year or 3 years. What can we count on? What can we prepare our patients for? Exactly. We want to be involved. Patients want to have their voice heard. It was mentioned already that NGOs are involved. Yes, we put a lot of effort into education, not just as a Polish association, but other advocacy groups. In a sense, it was already said in the first panel, there is a lot of burden on us when it comes to educating the society, educating local government, working in the regions. This is what we do, but we are not able to accomplish all that on our own. We need support. And going back to what you said, Dr. Gałązka, and what you said, it's about water. Well, in a town where I come from, there is water available at schools. Yes, there is freely available water. In my town, there is a very broad campaign supporting drinking tap water because it's healthy, it's good, and it's really bringing fruit. Maybe it's not as common and popular as we would love, but it's possible to do. We've got several points all over the town where you can use it, and so it's good. But what worries me is that these dosing containers tend to be empty in various locations. We should draw conclusions from the past. If we talk about prevention, prophylaxis, let's learn from the past, from good examples in the past. Thank you very much. In a moment, Professor Paweł Koczkoda is going to talk about nicotine addiction. So it's a very important thing, but I would like to ask Dr. Justyna Mieszalska to comment very shortly, because I understand that there is a postulate to have some sort of a target for these programs so that we know when the outcome is going to come. We know it's not going to be instant, but we want to know more or less if it's going to produce an outcome in a year, in 3 years. As a practitioner, do you think that's a good comment, that providing this information about when the outcome is going to come? Can you even do that? Well, 20 years ago, when we were designing the first prevention program, the outcome should already be visible, and I think it's not really happening. But what if we say, if you use it, if you come, then in 5 years this and that is going to happen? Do you do that? Well, I think it would be irrational to saying this to the patient, but I think patients should also hear, where they are going. You test your lipids, your lipid levels. You do an echo or ultrasound, because believe me, patients really want that. They think this is proper screening, this is proper prevention. Many patients really want to get that, whether they need it or not. They want to have a cardiac echo done. They don't really know what to do with that afterwards. And that's the point where we should consider the journey of the patient in the system. Because you get test results, let's say from the 40+ system, then the patient goes back to the primary care physician, and then they can be redirected, referred somewhere, or not, depending on the situation. If there is need, then there should be referred to a cardiologist, let's say, to an outpatient clinic, waiting months and months and months for that visit, and then you come or you don't. But in many programs, like in the HOOK program, I think you can do follow-up testing in specialized care, and you can even be referred to hospital if need be. But we only had one patient, a single patient, who under the HOOK program was instantly sent to a hospital. So I think that program actually saved his life. I see that patient sometimes in our corridors still, and he's breathing better. He's breathing better. So that program is, well, at least one single person really benefited from it. But telling a patient that, oh, you know, in a year it's going to be better, or in 5 years it's going to be really good, it's not really encouraging to anyone. It's not really convincing people. They still think, oh, okay, in 5 years, oh, I don't know if it's worth it, if it's 5 years. Oh, or we will, I don't know, delay the diagnosis. People say, oh, I'll go later. So I don't think that's the positive feedback. Patients should know, they should be clear about what's coming next, what's the journey, what's the pathway to take. Often patients come to an office with someone else, with another person. And that's, for a physician, that's a positive information, because that other person, whether it's a husband or a child, they listen and they understand more than the patient who is nervous and they may not remember everything, you know, where to go, what to do, and when to come back to a follow-up visit. Patients fail to remember what sort of medications they are on. So the consults under preventive programs, these visits take a very long time. But, well, when I was asking, I thought about the general information for the population. You know, if not 15%, but 50% of patients take part in a preventive problem, then we will have a reduction in the incidence of MIs or civilization-related diseases, or the reduction of the incidence of hard endpoints. Well, these endpoints should definitely be discussed in every single program, in every single study, because we always have some sort of an assumption behind every preventive program. But then the measurability of that and the outcomes, midterm outcomes, I think they are not really that measurable. But it's only for statistical purposes that we measure that. But of course, it does work on the patient's imagination. So it also tells us, it's a reference point for us as a population. Where should we go? Where the threats lie? This is why we do that. This is why we organize preventive programs, health policy programs. I nearly forgot what I was going to talk about. So preventive healthcare programs. Yes, we tend to forget things. Some people forget about the pandemics, but it's always coming back. Yes, it's always coming back. Let's put a full stop here, because I would like to. We still have 10 minutes until 1, so let's give the floor to the professor here, because in a week, next Tuesday, there's going to be the World Cancer Day. A week ago, our government passed some legal acts very much associated with what you do. You talk about nicotine addiction quite a lot. You work at the National Institute of Oncology here in Warsaw. So, Professor, what it's like with smoking, because we hear that 30% of the adult population smoke. Younger people start smoking in Poland, it seems. On the other hand, we've got legal regulations that are meant to cut down access on various kinds of tobacco products or tobacco-related products, especially to minors. So what's your view of this change? What can happen? Is it a step in the right direction? If it is, then is it a large step, or are there more needs to come? Yes, thank you for having me here. I'll try to give you a very brief answer, because I know you've been here for a very long time already and talking. I feel that What I'm saying is going to bring this entire day together. We are talking about cardiology here today, but I represent oncology, and one of the main threats and risk factor is still exposure to smoking. A large percentage of cancers in Poland are caused by exposure to smoking, even though every cigarette packet contains this warnings, health warnings and information. Regarding to what you said before, I think I heard a very good remark a week ago in a meeting in our institute. Someone said that in Europe, in the majority of cases, we are dealing not with healthcare systems, but systems of diseases. So we rather focus on diseases instead of focusing on making sure that we do not develop these diseases. And also in Poland, we do the same. We focus on treatment. So we talk about the reversal of the pyramid and reducing the amount of administered medications and so on and so forth, and reducing the red tape. But is it happening? It's a good question, and I think we should put more effort into it. Going back to your question, and remaining at the European level, the European Commission in Europe's Beating Cancer Plan, so that's a flagship document of the European Commission, assumes that by 2040 we will have the first tobacco-free generation, so the first generation who's not exposed to tobacco smoke. At present, so we are talking about people who have already been born, right? Yes. So until 2040, we would, among the adults, we would have only 5% of smoking. Now it's 23%. So over the next 15 years, we would really have to cut down on those numbers. We are talking about 4-year-olds, today's 4-year-olds. Yes, there is a very interesting analysis in Lancet Europe saying that we could cut down by 1.2 million the number of deaths of lung cancer among Europeans born in 2006 to 2010 until 2095 if we limit, maybe not legality of traditional cigarettes, but if those people were not exposed to tobacco smoke. So we've got many challenges ahead. Challenges like advertising and promotion of cigarettes. It's banned in Poland, but if you go to a store, you do see all kinds of things, all kinds of cigarettes. It looks nice very often. Yes, it looks very, very pretty. So is that advertising? Of course, it's in the legal act, it's called a display. So it's a loophole for the tobacco industry to be able to present their product. And unfortunately, we've got tragic outcomes of that. Referring to my own area, to cancer, National Register of Cancers tells us that every year, year on year, we've got increasing incidence of malignancies. The latest data from 2022 talks about 180,000 cancers, mainly breast in women and lung. The same goes for men. When it comes to mortality, since 2007, it's the leading cause of cancer death, lung cancer, both among men and women, even though breast cancer is the most frequent malignancy. I don't have to explain to you what tobacco smoke does to cardiovascular system. Nicotine is not neutral to our health. Let's not listen to that narrative telling us that these new tobacco-related products are healthier and better for our health. That is not true. Let's not say that. We know that these products facilitate sort of entry level to nicotine. We know that they are not neutral for us, for our health. So there's a lot of work to be done. Talking about the presidency, I think this is our common denominator, this risk factor, exposure to smoke, new tobacco products that are only developing in the market, and that should be definitely managed by us somehow. in a conference opening the presidency, there was a question asked, a question to experts, what Trojan horses they see for health, and mostly they managed tobacco, because the Ministry of Health is going to introduce some sort of a legal act limiting this or that, but the tobacco industry is a step ahead, always. So yes, we do an end game. So until 2030 or 2040, we give up on traditional cigarettes, let's say, and then we get a message, okay, do an end game, and then we are introducing e-cigarettes, tobacco bags or whatever. If that is legalized, we will get new products, because this is about business. It's not about health. So I think it's definitely something that should be mentioned during the presidency, because that's a common denominator, a risk factors that is still shared by all of us, despite everything that we have already been doing. In this legal act passed a week ago, there's a 6-month moratorium for the sellers of these products. So this is a time to get ready, and probably a time to develop new ideas and new solutions. Exactly. We've got a whole package of things that should be introduced that were developed by the WHO, that worked out elsewhere. Back in the 90s, Poland was presented as a gold standard for anti-tobacco policy, and because of that, yes, we do see some reductions in terms of lung cancer incidents, but we stopped at some point, I think. We can do all kinds of things that are based on evidence-based medicine, that different than we have been doing so far. So, for instance, plain packaging for cigarettes without any advertising or trademarks, hiding nicotine products like in Finland. You go to a shop, you go to a store, and you cannot see that. You cannot see those products at the cash register.
Yes, and you simply have to say exactly what you want to get, and only then you are served the product. And I witnessed a few weeks ago the following situation. I saw a big glowing cupboard with different nicotine, or actually tobacco products, which said that it is a price list, because it actually had all those products, and prices were also quoted, and it looked like a vending machine where you can go, just put in a banknote and take a pack of cigarettes. We also have a very nice OECD report that is on cancer, and it went out at the end of the year, and it also says that it is proved once again that fiscal policy is the most powerful tool of health policy. Our wallet is more important to us than our health. That report says that the most convincing argument for consumer is always money related. That something is too expensive, and that's why they don't buy cigarettes. And only the next place is occupied by the argument that I don't buy it because I can develop a cardiovascular disease or cancer. So once again, education, education, education. If it is not mandatory, well, unfortunately, it will not exist in a universal way. The discussion about that is going on. Well, it's already past 1. Can I add anything? Yeah, please, Senator, but 45 seconds. Education. Now we are looking for solutions. I'm now meeting Minister Nowacka. Even if those classes are not mandatory, we are thinking how to encourage teachers, parents, principals to attract children to the class. It is really crucial because we can't let it go. Thank you very much, and very warm greetings. Well, perhaps some additional credits in recruitment to the next level education. We'll think about that. Some benefits. They simply have to have some benefits. Thank you very much for those declarations, and we are going to monitor that. 45 minutes. The professor finished his statement very well, saying education, education, education. And it must be also supported by a strong state. It is proven. We are not very responsible as individuals, and it will not change for a long period of time. And even in the countries where these solutions are implemented, where the population has greater level of health awareness, states still reach for instruments that will create a health conducive environment. Many years ago, we decided that all children born in Poland are subject to the screening of their hearing. A few years ago, we also decided that all the children will be subjected to the screening for the SMA. A few years ago, another decision was made that children to be accepted in primary school must have the checkup of 6-year-olds, and then all children go through that. And if we focus on prevention that is focused only on free choices of our citizens, even vis-a-vis things that have a critical significance for their health and life, then still for a long time we will not be able to announce any success. Unfortunately, Article 68 of the Constitution, which refers to the provision of equal access to health care when financed from public funds, and the commitment of the state to decrease risk factors is such that the systemic legal solutions will really have to decrease the risk people pose to themselves. We have some destructive streak in ourselves, and this is about the subsidiarity represented by the state. The state creates the traffic rules that are mandatory for everyone, or air traffic, but the state must also identify some basic rules of moving around in the area of health. I'd rather translate that to the subjects of safety and security. Safety and security of the state, because then we will simply have to identify some minimum standards, some common denominator that would be mandatory for all the citizens. If we do not adopt them, for a long time, we as citizens will constitute a threat to ourselves. Thank you very much. So we are going to finish our debate. Thank you very much for this discussion. I know that we will continue that, and there will be a follow-up, not only due to our presidency in the Council, not only in the coming months, not only on the occasion of the 5th anniversary of COVID. I'm sure, unless you want to add anything, I'm just looking around. 30 seconds, not more, 30 seconds. Well, perhaps 15 will be sufficient. Education? And as far as money is concerned, just to reiterate what was said here, let us talk about a sugar fee. Sugar fee. Well, it's a lot of money there. And to conclude, I also have to say that what Dr. Gałązka-Sobotka said is also something addressed to the government. The government must be bold when they talk with tobacco industry, because alcohol and tobacco are the main players in the state budget. We as citizens make our choices, and we as states also must make choices, because health and
Try for European cardiovascular health plan due to its unique position of the presidency in the first half of 2025. It's really needed for Europe.
Bardzo dziękujemy.
Thank you very much indeed. Thank you very much for these comments, and I would like to remind you that this was our debate.
Proszę, ale myślałem, że już pani senator nie...
Can I? Yeah, sorry, I thought that you were gone. Okay, the final conclusion. Safe and secure state will depend on the health safety of our citizens. Yes, we are going to monitor the situation. There were many ideas. The ban on selling alcohol at gas stations at night, for the time being, it is put on a hold. I think that many people have not forgotten about those postulates. You talked about that? That sometimes it is difficult to find staircases in different buildings. You can't use them. Although it is easy to find cigarettes in different stores. There are some other countries where you really have to look very hard to find cigarettes in a store. And you have no problem to find stairs. It's a different situation in Poland. So when I am asking for the stairs, they tell me, well, you must be sick that you can't take the lift. No, I say, I want to be healthy. That's why I want to take stairs. Water is very important. Have water very close to yourselves. Hydrate and use the stairs. Climb the stairs. And this is what we can talk about. This discussion is going to continue. in this group, but also in other more extensive groups. Thank you very much for your participation in the debates. Dr. Małgorzata Gałązka-Sobotka, President Monika Kaczmarek, Justyna Mieszalska from Warsaw Medical University, Professor Paweł Koczkodaj, with us Mr. Georg Scherer-Fuchs from Novartis. Thank you very much. And now, those who are with us, please take coffee and have some unofficial talks, because I believe that the follow-up will come very soon. And hope to see you again during our next meetings and discussions, also under the Polish presidency. Have a good evening and be healthy.
Dziękujemy bardzo za obecność.